Hey, Wen.
E agora, tá ouvindo?
Yeah,
Ah, agora
now
sim.
we
Eu não
hear and
sei, não
see you.
conseguia. We cannot unmute. I was not able to unmute myself. But,
Now it's working.
yes. Mas obrigado por aparecer aí.
Eu que agradeço. Obrigado vocês pelo convite.
É, daqui a pouco vocês têm que viajar domingo, né?
Isso, eu
Domingo?
chego domingo à noite.
Domingo,
Eu chego
domingo em
domingo
São
à
Paulo.
tarde.
Uhum,
Uhum. Você sabe o hotel, aquele Mercure,
Uhum.
Capote.
uhum,
Não, Alves Guimarães, não. É Capote Valente.
Capote, capote.
Capote Valente, isso mesmo. Uhum.
uhum.
Tudo bem,
Talvez
Wenzinho?
tudo, correria. Tava atendendo consulta.
Imagino, né? Imagino que essa semana foi punk pra você.
É, tava atendendo consulta, mas é uma boa, né? Tem gente de outro estado, outra cidade, que é ser atendida, você consegue, né? Não precisa vir até São
Uhum,
Paulo. É.
uhum. Wenzinho, você apresenta a Mussi.
Não, apresenta aí, eu caí de paraquedas aqui.
Ah, não, vai você.
Não. Você fala bem. Moço, ninguém quer apresentar você, esse é o problema.
Todo mundo quer apresentar você, Mussi.
Não, ó, deixa a Carol apresentar. Estamos falando português, né? Mas acho
Tamo.
que mas o tá
Mais um
sendo
minuto.
transmitido ao vivo para YouTube. É.
Uhum.
Ok. Carol, você fala, o Hospital Caridade já
Hospital
mudou,
Governador Celso Ramos.
viu, Carol?
Tá bom. It's time. Should we?
Go ahead.
Okay. Hello, everyone. I'm glad everyone is here tonight. Tonight in Brazil, in fact, because we have a great friend of ours, Professor Mussi from Florianopolis, Brazil. He's from Hospital Governador Celso Ramos, and he's going to speak tonight to us about the third ventricle and its surgical applications. So, Mussi, thank you very much for being with us. Professor Wen is also with us, the president of the International Rhoton Society, and we are going to have another great Rhoton's Anatomy Day in the brain, right? Okay, Mussi, it's yours.
Ok. First of all, thank you, Carolina and Wayne, for the chance to participate in these talks, Rhoton's Anatomy Day. It's a great honor for me to participate. Thank you very much. I'm going to talk about the third ventricle and its surgical application. I was a fellow in Dr. Rhoton's laboratory from 1998 to 2000. The third ventricle is a small, narrow, rectangular space cavity located deeply in the brain. And that makes it a challenge when we have lesions inside the third ventricle that require surgical removal. The third ventricle has two lateral walls. It has an upper region, anterior region, a floor, and a posterior part also. And we are going to review during this lecture all the parts of the third ventricle and the surgical approach to the third ventricle. So starting with the sagittal cut, we can already see that the lateral wall of the third ventricle has like a sulcus, which is called the hypothalamic sulcus, that goes from the aqueduct until the foramen of Monroe. And this sulcus divides the lateral wall of the third ventricle into two regions. One inferior to the sulcus is the hypothalamus, and the one above the sulcus is the thalamus. And in the thalamus, we have the massa intermedia connecting both thalami. If we look to the superior portion of the third ventricle, we see the internal cerebral vein, and we see the fornix. And the fornix is attached superiorly to, here we can see, the fornix is attached superiorly to the septum pellucidum. The septum pellucidum attaches anterior to the foramen of Monroe. It attaches inferiorly to this portion of the corpus callosum, which is called the rostrum of the corpus callosum. And posterior to the foramen of Monroe, it attaches to the fornix. And here we see again the hypothalamic sulcus dividing the lateral wall with the thalamus and hypothalamus. Here on the foramen of Monroe, we can see the fornix here, and very near to the fornix, we can see the anterior commissure and lamina terminalis in the anterior portion of the third ventricle. The third ventricle is the most common approaches to the third ventricle are from above and from posterior, when we have pineal tumors, for instance. But we also have, we can approach the third ventricle anteriorly, and now with endoscopy, we can also approach, for instance, with pituitary tumors that go inside the third ventricle, we can also approach from inferiorly through an endoscopic approach. When seen from above, the third ventricle, the superior portion of the third ventricle, can be described as having 5 layers. The first layer is the fornix bilaterally that we see here. And if we cut the fornix here, here's the fornix attached to the septum pellucidum. If we cut the fornix and retract the fornix posteriorly, we can see the second layer, which is the layer of tila choroidea that goes laterally until the choroid plexus on the lateral ventricle. We can see here this layer of tila choroidea. Then we have a vascular layer where we will find the internal cerebral veins bilaterally, and the lateral posterior and the medial posterior choroidal arteries, with which go here on the roof of the third ventricle, these arteries here. And below the vascular layer, we have another layer of tila that attaches to the lateral side of the thalamus. So the first layer of tila attaches to the choroid plexus on the lateral ventricle, and the second layer of tila attaches here to the lateral side of the thalamus. And this makes a space which is called the velum interpositum, where we find the vascular layers. Here we see the medial posterior choroidal arteries, and here we see the veins. So we described 1, 2, 3, 4, and we can describe a fifth layer if we consider the choroid plexus that is attached to the inferior layer of tila. We can see here by transparency the choroid plexus attached here to the inferior layer of tila. So if we open this inferior layer, then we are inside the third ventricle. So this is the point where the inferior layer atilla attaches to the lateral wall of the thalamus, and it goes from the foramen of Monroe posteriorly until the pineal gland. And then this layer atilla attaches to the superior portion of the pineal gland. By removing this inferior layer atilla, we can see the massa intermedia here connecting both thalami. We see the internal cerebral veins, and here forming the internal cerebral veins, the thalamus striate veins bilaterally, and also the anterior septal vein at the level coming from anterior to posterior and draining here near the foramen of Monroe. Now, the anterior portion of the third ventricle, we have just seen the roof of the third ventricle. Now we are going to see the anterior portion of the third ventricle. On the anterior portion is formed by the lamina terminalis. And in the upper portion, we see here the anterior commissure just anterior to the fornix. So the anterior layer is formed by the lamina terminalis. Here we see the pituitary stalk, the carotid artery, anterior communicating artery, and we start to see the floor of the third ventricle, the inferior part of the third ventricle. And in the inferior part, from anterior to posterior, we start seeing this recess here, which is the optic recess related to the chiasm here, optic recess, and then the infundibular recess related to the pituitary stalk. Now we see the anterior portion of the third ventricle here, lamina terminalis. We see the chiasm with, now this is the inferior portion of the third ventricle. So in the inferior portion from anterior to posterior, we have the optic recess, infundibular recess, then the tuber cinereum, where we do the third ventriculostomy. Then we have mammillary bodies and posterior perforated substance and the mesencephalon. So this is the inferior portion of the third ventricle seen from above. So near the foramen of Monroe, we have the fornix here, the anterior commissure. Just below anterior commissure, we have lamina terminalis. Then we have the inferior portion of the third ventricle with optic recess, infundibular recess, tuber cinereum hidden here by the massa intermedia. Then we have mammillary bodies that we can see here, and this is going to be the mesencephalon, posterior perforated substance, and here the pineal on already the posterior part of the third ventricle. In this cut, this is a sagittal cut near the pineal region, and in this sagittal cut, we are retracting the inferior layer of tila, and this inferior layer we can see attaching here to the lateral side of the thalamus and creating here this space, which is the velum interpositum, where we have the venous structures and the internal cerebral veins and the medial posterior choroidal arteries. And here we can see how this inferior layer atilla attaches above the pineal gland. And here on the pineal gland, we have pineal gland, internal cerebral vein, and the corpus callosum, the splenium of the corpus callosum. This is now a view of the posterior portion of the third ventricle. The pineal gland, this is from anterior to posterior. This is the splenium of the corpus callosum, internal cerebral vein, draining here to vein of Galen. And we see that the pineal gland attaches to the posterior part by two structures, the pineal commissure and the posterior commissure. I'm sorry, abenular commissure and posterior commissure. And here we see the inferior layer atilla attaching to the upper side of the pineal gland. So this creates these spaces, which is called the suprapineal recess, the pineal recess between abenular commissure and posterior commissure, and posterior commissure and aqueduct. So this is the posterior part of the third ventricle. Whenever we come from posterior to the third ventricle, we usually come through the suprapineal recess. So we have the two main approaches to the third ventricle are from the roof and from the posterior region. But we can also approach from the anterior region and, as I said, from below. So I'm going to show all these approaches, starting with the anterior approach through the lamina terminalis. So one way of approaching the lamina terminalis is by a bifrontal craniotomy. And here we see the pituitary stalk, the olfactory nerves, the chiasm, and we start to see the anterior communicating artery, pericallosal arteries, and this is the lamina terminalis. We see the corpus callosum here, the genu of the corpus callosum, and all this area here is anterior commissure. So this can be opened and gain access to the third ventricle, like this. The lamina terminalis can also be approached by approach through the Sylvian fissure, but it's more difficult to expose as much as we can do if we go interhemispheric approach. And here we see the optic recess, the infundibular recess, tuber cinereum, and mammillary bodies. So one of the most important approaches to the third ventricle is through the roof of the third ventricle. And to get to the roof of the third ventricle, we have to expose the corpus callosum and do a small opening of the corpus callosum, get access to the lateral ventricle, and then we'll be able to access the third ventricle. So to do that, we do an interhemispheric approach. And if we want to get to the third ventricle, we have to imagine the position of the foramen of Monro. And by looking at this slide, if we see the anterior cerebral artery coming around the genu of the spleen of the corpus callosum, the genu of the corpus callosum, about 2.5 centimeters posterior to this genu that we can see in surgery is the location, more or less the location of the foramen of Monro. So we don't start the opening of the corpus callosum here. We start about 2.5 centimeters. Of course, we can use neuronavigation to check the position. And then we start opening the corpus callosum in order to get to the foramen of Monro. So this is illustrating. Here's the genu, the turning around of the anterior cerebral artery, and more or less 2.5 centimeters we'll get to the foramen of Monro. Looking to the foramen of Monro, we'll see the anterior septal vein, the thalamus striate vein, the plexus choroid, the choroid plexus, and the choroidal fissure. The choroidal fissure is the space between the fornix on one side and the thalamus on the other side. Of course, this is a virtual space. The choroid plexus attaches on the one side to the thalamus and to the other side to the fornix. But it can, the side of the fornix can be opened to gain access to the third ventricle. This we can do in order to enlarge the foramen of Monro. Of course, we can do an approach for small lesions just through the foramen of Monro. Sometimes we don't need to open the choroidal fissure, but if we have a more posteriorly located tumor or a larger lesion, we can enlarge the foramen of Monro by opening the choroidal fissure always on the forniceal side in order to avoid the veins that come from the thalamic side of the choroidal fissure. This was published by Wayne, Dr. Rhoton, the transchoroidal third ventricular exposure. And this is, we see the attachment of the choroid plexus to the forniceal side. And we can open this and expose the third ventricle, going between the two internal cerebral veins. The internal cerebral vein on the right side, we don't see in this slide, but we are going here between both veins. Then we open the inferior layer atilla, and we get to the third ventricle. This is the massa intermedia, and this is the posterior commissure. So here is already the pineal gland. We are here at the level of the atrium. Of course, as we go more posteriorly, this dissection gets more difficult because of the curve of the fornix at the level of the atrium. And as we can see in this slide, the only structure that is still on the way of this enlargement of the foramen of Monro is the anterior septal vein. And so we see the massa intermedia, the anterior septal vein, which could even be coagulated here if needed, or sometimes, or preserved, depending. Also, another approach, superior approach to the third ventricle, is dissecting between both fornices and doing an interforniceal approach to the third ventricle. And we see the massa intermedia and posterior commissure. This is the aqueduct and the pineal gland. And we go also between the two internal cerebral veins. The difficulty of this approach, if we don't have natural separation between the fornices, as we have in, for instance, when the presence of a cavum septum pellucidum separates the fornices, is that we can damage in this dissection the fornix bilaterally. So this is one of the problems of going in interforniceal. This is a surgical illustration. So the interhemispheric fissure is dissected, dissecting until the corpus callosum. We see here the turning around of the anterior cerebral artery on the corpus callosum. About 2.5 centimeters is the point that we start opening the corpus callosum in order to see the foramen of Monro. We can see here that if we started opening anteriorly here, we would have a very large opening of the corpus callosum. And in this case, we just got directly to the foramen of Monro. We can see the choroid plexus, and we see the fornix here, the choroidal fissure, anterior septal vein, the choroid plexus, and the foramen of Monro. This is an illustration, a colloid cyst with hydrocephalus, small colloid cyst. We can use the superior approach, again exposing the interhemispheric fissure. Opening the corpus callosum, we see the foramen of Monroe, anterior septal vein, lateral ventricular, the thalamus striate vein. We see here the fornix here, septum pellucidum. We can coagulate the choroid plexus, open the choroidal fissure. We see here fornix on one side, thalamus on the other side, here preserving the thalamus striate vein. And by doing this, we enlarge the foramen of Monroe, and we have a larger access to remove the choroid plexus. And removal of the choroid plexus, we see one thalamus striate vein on this side, another on the other side, and the anterior septal vein here, and the fornix completely preserved, and the colloid cyst removed. We can see here, and this is the post-operative CT. And this is a small incision in the corpus callosum directly to the foramen of Monroe. This is another example, craniopharyngioma that was removed initially by a Transylvian route, and there was a section of the tumor located inside the third ventricle that could not be removed. And we can see here, in this case, the ventricle on the right side is very small, so we went through the ventricle on the left side. And I'll show quickly here a video, the callosotomy, and just to show how we did the opening of the choroidal fissure. Here, first opening the septum pellucidum, communicating both ventricles. Then we can see the foramen of Monroe already with the crane. Oops, I'm sorry. Then we can see the foramen of Monroe with the craniopharyngioma, opening a little bit more. Here, I want to show a little bit of opening the choroidal fissure. So this is the fornix. We are on the left ventricle, so it's different from the choroid cyst that I showed before. We are coagulate the choroid plexus, and we start opening on the forniceal side. This is a higher magnification. We can see the choroidal fissure, and we start opening with the seizures, and we open the choroidal fissure. By doing this, we are going to enlarge the foramen of Monroe. So here, getting close to the foramen of Monroe, this is the anterior septal vein. In this case, we coagulated the anterior septal vein because it was on the way, and the tumor was more posteriorly located, but the thalamus striate vein was preserved. So here we can see, now we can see how we enlarged the foramen of Monroe, and then we proceed to debulking the tumor and dissecting the tumor from the thalamus, a craniopharyngioma. So this gives a larger space to remove the lesion. We can see the adherence with the thalamus. And this is the post-operative MRI showing complete resection. This is another case. This all showing approaches through the roof of the third ventricle. This was a 7-year-old child with a lesion on the inferior portion of the third ventricle with a galactic syndrome. seizures, galactic seizures. She was having everyday seizures, and we decided to approach this lesion through the roof of the third ventricle. And if we see the coronal cut, we can see that in this case there is a small cavum of the septum pellucidum, and if we look here, we can try to go through the corpus callosum and do an interfornicile approach to get direct access to this lesion inside the third ventricle. So we see that there is no dilation of the third ventricle. It's a normal. We can use neuronavigation also to check our position. And in this case, we are doing interfornicile approach by using this natural separation between the fornices. And this is showing the lesion inside the third ventricle. It was a amartoma of the hypothalamus, hypothalamic amartoma. And after resection, she didn't have she didn't have any deficit and control of the seizures. This is immediate postoperative MRI showing the approach through the foramen of Monroe. This is showing also anterior approaches through the lamina terminalis, here through a lateral approach through the sylvian fissure and opening here the lamina terminalis. And also we can use a pretemporal approach to expose this region, the supra, I'm sorry, here showing the chiasm, the infundibular stalk, and we can get through a pretemporal approach a larger exposure of the interpeduncular area and look to the third ventricle from below. Of course, also the endoscopic view could be used to get to the inferior portion, but this is to show the basilar artery, so we can go to this region and have this vision where we see the chiasm here and the inferior portion of the third ventricle. And in case of craniopharyngiomas and tumors in this area, we can approach the third ventricle from below. This is a surgical exposure. We see the tumor craniopharyngioma, here the chiasm. So first the tumor was resected through between both the optic nerves. Then we go to the region between the carotid and the optic nerve. And then we do the pretemporal approach, liberating the uncus. We have to dissect this arachnoid that makes the uncus together close to the carotid artery. So we have to dissect this in order to do the pretemporal approach. The uncus we see, and then we'll work in the pretemporal approach between the carotid artery and the third nerve. And we can go on, and then we'll find the portion of the tumor there in the interpeduncular cistern and the portion that goes to the third ventricle. And here, exposing the third ventricle from below, resecting the tumor that was going inside the third ventricle through a pretemporal approach on the right side. So we expose the third ventricle from below in this case. And now we already saw from above, from anterior, from inferior, and now the other major approaches to the third ventricle, which are the approaches from posterior, direct directed to the area of the pineal gland. So in this region, we'll work in this region with the splenium of the corpus callosum, the pulvinar of the thalamus, the posterior part of the parahippocampal gyrus, and the lingual gyrus here, the calcarine sulcus, and this area can be approached either superior to the tentorium or inferior to the tentorium to get to the pineal region. This is a view of the third ventricle, the pineal gland, the quadrigeminal plate, trochlear nerve, and we are going to go through the tentorial surface of the cerebellum. Tentorial surface is high, the highest point is near the midline, the culmen, and so whenever we come from more laterally, we have a better view of the quadrigeminal plate and the pineal gland. Here we are going to deal with the deep venous structures, the basal vein of Rosenthal, draining here to the galenic system. Also, we have veins inside the calcarine sulcus, and we have also the internal cerebral veins coming here, all draining to the galenic system. Here we have a view of the basal vein of Rosenthal, the lateral mesencephalic vein, and on the midline, we have another vein that comes from below to superiorly, which is called the precentral vein. Here, approaches to the pineal, we have mainly approaches through above the tentorium and below the tentorium. This is an approach above the tentorium, an occipital transtentorial approach, in posterior interhemispheric approach, where we see the falx, the straight sinus, the tentorium. This is the splenium of the corpus callosum. This is on the left side. So this is the calcarine sulcus. This is posterior part of the cingulate gyrus. This is lingual gyrus. And we see a vein draining the posterior portion of the splenium of the corpus callosum. We see the basal vein of Rosenthal, another vein draining through the calcarine sulcus. And this is the galenic vein of Galen. And if we dissect here, we can see the internal cerebral veins coming from the roof of the third ventricle. This is the splenium, the pineal gland, and this is going to be the suprapineal recess. So we can go more laterally also, open the tentorium, and see this vision more from lateral to the pineal gland. This is the internal cerebral vein on the other side, and this is the precentral vein on the midline. We can even go more laterally to the parahippocampal gyrus, and we can also see a very good view above the galenic system. And this gives us access to the pineal and to the posterior portion of the third ventricle. Another approach is infratentorial, supracerebellar, through the midline. This is exactly the same specimen as before, so we are seeing exactly the same anatomy, but from a different surgical perspective. So we see the culmen of the cerebellum, the tentorium bilaterally, vein of Galen here, basal vein on both sides, precentral vein, and internal cerebral vein here. This is the pineal gland, this is the suprapineal recess, and we see the internal cerebral veins with the posterior medial choroidal artery going to the velum interpositum, going here on the suprapineal recess. Laterally, we see the pulvinar of the thalamus, and this is the superior colliculus of the quadrigeminal plate. And laterally, we see basal vein of Rosenthal, and here the precentral vein. We can gain direct access to the third ventricle if we open this inferior layer atilla, but in case of tumors, this area would be filled by the tumor, and the veins would be retracted laterally and superiorly. So this is showing direct access to the third ventricle, and here the velum interpositum on the roof of the third ventricle. Just to see how the anatomy is compared with the previous approach, we can open here the tentorium, and we see the calcarine sulcus, and we see that the superior limit of our view is going to be here, the vein of Galen. Different from the other approach where we had a much better view above the vein of Galen and of the interhemispheric fissure. So this is the pineal, and we can also come more laterally to gain access through this slope of the tentorial surface of the cerebellum, and we can even open here to gain access to the parahippocampal gyrus. So the calcarine fissure is located here. It's exactly the same specimen as before, and this is the parahippocampal gyrus. This is the basal vein of Rosenthal on the other side. And this is an illustration. We see a tumor located in the posterior part of the third ventricle. This could be approached either supratentorial or infratentorial. I'm going to show here the tumor, posterior part of the third ventricle. And this is, it was approached through an infratentorial supracerebellar approach. This is the tumor. The tumor retracts the veins laterally and superiorly, and we can debulk the tumor and resect this tumor. And after resecting the tumor, we see inside the third ventricle, the thalamus bilaterally, the massa intermedia. And because we are looking from inferior to superior, we see the roof of the third ventricle with the fornix and the inferior layer of tila with the choroid plexus. And the mesencephalum is located here. So this, we see the internal cerebral veins and the basal vein of Rosenthal laterally. And this is the post-operative MRI. This is just to show an example of the approach. So supracerebellar approach, we see the region here occupied by the tumor. We see the precentral vein. The precentral vein is coagulated in order to facilitate the removal of the tumor and to facilitate that the cerebellum goes down after the coagulation. We do a debulking of the tumor, which makes it possible to dissect the tumor from the veins. And here, already dissecting from the mesencephalum and removing the tumor, we are inside the third ventricle. So this is the foramen of Monroe. This is the choroid plexus on the roof. And this is the thalamus on the lateral side. Oh, I'm sorry. The thalamus on the lateral side. And we see here the foramen of Monroe on the other side. So completely exposure of the third ventricle. So we reviewed the anatomy of the third ventricle and the surgical approaches. I thank you again for your attention.
Mussi, this is always a great talk, and I'm always learning a lot from you, my friend. Thank you so much. Let's see if we get questions from the participants. Guys, you can also open your mic or write your questions at the chat box. Let's see if anyone wants to ask. While the guys are thinking, Mussi, let me ask you this. Is there any time when you would rather go to supracerebellar in the paramedial route, initially, I mean? You seem to favor very much the median route, right? But is there any case you would...
For pineal tumors, usually we do infratentorial supracerebellar because I think you get a more relaxation of the brain and easier, the brain is more relaxed to go to the pineal region. But for instance, small tumors, children, that it's more complicated to get a semi-sitting position, then we do the transtentorial supracerebellar approach. This in cases of pineal tumors, but of course, the supratentorial transtentorial approach, posterior interhemispheric approach, is also can be used for instance, not just pineal, but focal tentorial meningiomas would be better than the infratentorial approach. For instance, lesions of the thalamus, we can go through supratentorial approach. So there are cases where you have to choose according to the pathology. But in pineal cases, sometimes you can go either superior or inferior. Sometimes it's more even I think how the surgeon feels safer, more is more used to go either some surgeons go more supratentorial or more infratentorial.
I see. So you think it's a personal matter. It's like
Sometimes,
experience.
sometimes according to the age of the patient and the lesion, small lesions, I think you can use the supratentorial. I think it depends the lesion, the age of the patient, many things.
Okay. So I think we have a question here from from Lord Voldemort. He's asking, I guess it's he. He's asking, what position do you use for occipital transtentorial approach? Do you always use semi-sitting, I guess?
No, superior transtentorial approach, I always operate with the patient lateral position. And for instance, if I want to go through the right side stays down. So the brain can fall by gravity and you don't have to do much retraction. So I use the lateral position. And for infratentorial, I use the semi-sitting position.
Is there any patient that you would not consider putting in semi-sitting?
For children, I think it's more difficult to put in semi-sitting position. Then I usually prefer transtentorial, and it depends.
I see.
By
Do we have...
bilateral position, you mean like something like park bench?
Park bench, yes.
Oh.
I think I can even show how I have the presentation here. If
Please do.
I showed some.
Please do.
Okay, I have here, for instance, how I position. For instance, this was huge. Let me show here. Huge folk tentorial tumor.
Maybe you have to share presentation, right?
I'm sorry. Let me share. Share. Share.
There you go.
Okay, so this is a huge focal tentorial tumor, and we see that it's above the venous structures. So of course, this is much better to go supratentorial. This is the position. So we approach with the side that we are going to go facing inferiorly. And this is the craniotomy, always exposing the sinus, the sagittal sinus. And we go here interhemispheric. And in this case, we could open the falx, and we see the brain on the other side, the meningioma, and resecting here. And another case, another focal tentorial meningioma. This had a complete obliteration of the straight sinus in angiography, so we could remove. This is showing the relationship with the straight sinus, so this is much better to go from above. The resection. This patient had a little bit of diplopia in the postoperative period, but recovered. And this is the postoperative result. Let me see another. For instance, this case here, thalamic tumor, GBM. If we see here in the MRI, it's much easier to go from interhemispheric approach. Same thing, this is left side, so it's facing down. We go here, this is the splenium of the corpus callosum. We can open the posterior portion of the cingulate gyrus. We can see this with the neuronavigation. And then we get to the tumor, and this, you see the choroid plexus on the atrium, you see the fornix, and you see the removal of the thalamic tumor. You see here the ventricle with the choroid plexus. This is the atrium. This, you see the galenic system is here, and this is the postoperative. So these are illustrations of how the same approach used for the pineal gland can be used for other lesions located in this near this area.
That's great, Mussi. Do we have any more questions? When do you have any other questions, or the guys who are with us?
You know, Mussi, do you ever consider how steep is if you want to go supracerebellar, infratentorial, sometimes, the upper surface, the tentorial surface of cerebellum is so steep, and sometimes not so steep. So do you have any consideration about this?
I personally didn't change because of this. I don't remember any case that I had to change because of this, but this can be a problem. If it's too steep, then probably better you go above. But I didn't have any case that I had to change because of this angle of the tentorium. I don't know. Did you? What do you think, Wayne?
No, I am the one who's asking questions.
We do have another one here.
Yes,
Do you
let
use
the audience
lumbar
ask.
drainage for occipital lobe relaxation in occipital transtentorial if you use lumbar drainage?
Yes, if this is the main problem of this approach, posterior interhemispheric approach, is where you have edema or hydrocephalus, and it's very difficult to do the interhemispheric approach because to drain the cerebral spine fluid, you have to have first the corridor to get access to the drainage. So it can help to put a lumbar drainage. We do this constantly, not always, but when we think that it's going to be too difficult, we do a lumbar drainage, or when we have hydrocephalus and you can do a ventricular drainage also, then you can just do a puncture of the ventricle, and then you have a relaxation for your approach. But this is the problem, because the main problem of this approach is if you retract too much, you can damage the region around the calcarine sulcus, and you can have visual deficit. This is the main consideration, I think.
Mm-hmm. Great. I think we are pretty much on time, Mussi. Thank you so much. Thanks everyone for being with us. Thanks, Wen.
Thank
And
you.
I think we have a new date in December, right? At the last Friday of December.
Oh,
So
yeah.
thank you, Mussi, so much. We all
Thank
learned a
you.
lot. We see each other very soon.
Yes, we're gonna
Okay.
have a dissection course coming Monday at the University of São Paulo in São Paulo, Brazil. So it's gonna be an exciting week ahead of us. Thank you, Mussi. Thank you, Carol.
Thank you again.
Thank
Thank you,
you
everyone.
all. Bye bye.
Bye-bye.
Good night.
Thank you, Imad.